So Lori has got some pathology, so unfortunate for her, but good for us. Let me see if I can turn this on. Let's see here. All right, bear with me. I'm under pressure here. Let's see, general, I think I got it. I think I'm good. Let me make sure I got the right one on. Yeah, I think I got it on there. Okay, so first thing we're going to do is look at the anterior ankle joint recess. All right, let's see. So proximal is going to be to my left. We're going to start in a long axis view. So, and this one does have an arrow. Sweet. Okay. All right, let me bring up my depth a little bit. All right, so what we're looking at here is a long axis view. This is distal tibia. Okay, here's fat, intra-articular but extrasynovial. This is the ankle recess down here, and here's the hyaline cartilage of the talar dome. So anytime you're in here injecting, you're technically intra-articular. As long as you get deep, you can make out maybe the capsule right here over top of that. So if my needle's deep to that, we're good. But remember I said, you know, if you looked and you try to do, oh geez, I really got increased turning my head this way. Maybe, hold on. So what I'm getting at is if I had to do an injection, I don't know if you're looking at the screen, my hand, if I try to put a needle here, boy, that is really hard to get underneath of that, okay? So if you needed to do an ankle aspiration or an injection, my preferred approach is if I rotate the probe 90 degrees and I see hyaline cartilage, which is right here. This is fat, okay? Here's artery. Well, so I go, well, you know what? I think I can get into that joint by, I'm pushing on the side of her foot, if you guys are looking at my finger, and I can just go about 1 centimeter down, and if I go straight across, my needle's going to be entering in right there. And I can put an injection or aspiration much easier than trying to scave along the top of her foot, which is going to be uncomfortable. Does that make sense? All right, so I just wanted to show you that. All right, so that's the anterior ankle recess and an approach for an injection. The actual tendons of these, we're going to show you. This is going to be your tibialis anterior right here. Her EHL with its low-lying muscle right there. Remember I talked about how the artery sits right on top of it, or it sits right underneath of that. Let's see if we can visualize the fibular nerve. I maybe make out that it's right here. Let's bring up our depth a little bit. So that's probably the best view I can get of that. And then the extensor digitorum longus is probably these fibers that are right up here. As we go down, they should start to splay out, and you can see that. This might be the peroneus tertius way out here. And then the extensor digitorum brevis is this stuff. For those who do EMG, that's what you're recording for your fibular studies. Sorry, Jeff, did I say that right? Good. All right. So that's anterior ankle, and you certainly can play, for the interest of time, I'm just going to skip, but remember I preach just trying to get on structures and going into long axis. So that's a tibia anterior and long axis, right? Just kind of practice that in your lab sessions, particularly when we start talking about the ankle, getting good visualization, making sure that, because these tendons are all going to sit close to each other. So with that said, let me show you the medial ankle. So Laura, I'm going to have you lay on this side, yeah? So I'm going to use a bolster. Okay, and I'm going to look at her Tom, Dick, and Harry. So let's see if we can show you that. All right, so here's her posterior tibialis in short axis right here. Here's flexor retinaculum sitting right on top. So technically this is the tarsal tunnel. Let's see if we can make Mickey look good. She's got 3 ears. She was probably up near 3 Mile Island maybe, I don't know. So, so 3 veins, right, and an artery. And then the tibial nerve sitting right here, and then the flexor hallucis, hers is actually pretty well visualized here, and then the FDL sitting here. All right, so let's just follow those structures distally, and again, you're going to have to kind of play with your gel. And now, if you're pretty astute, if you look down here, kind of, someone's looking after me, here's her deltoid ligament right here, and if you can dorsiflex the ankle a little bit, and that's probably the best view of her deltoid right there, the deep posterior talar ligament right there, all right? So that's one of the more clinically relevant. So if you can have them get on a bolster, dorsiflex, and get rid of some of that anisotropy, that's probably the best view that I can give you of deltoid. If I rotate the probe a little bit, I can probably show you the superficial fibers. Hold that there. You're seeing this one's going down to the sustentaculum talae right here. That's probably one of the superficial parts of the deltoid. So again, you have to name it based upon what you're seeing, but the deep one is one. If you could just practice that one, that would be good. And then as I keep going with the posterior tib, remember I told you the posterior tib is going to take you to the deltoid. The FDL is going to end up sitting on top of the sustentaculum tali, which is right here. And then remember I said posterior tib has a little bit of fluid around it. Don't get too excited. I know it's lunch, but this is not true tenosynovitis. It's, I'm sure if we put Doppler, it's going to look fine. But remember I said it also takes you to the spring ligament, which is right here. So it comes off the sustentaculum tali, and if you follow that over, it's going to insert onto the navicular over here. So this is her spring ligament. So if you get pathology of this, you may want to take a gander at this thing sitting right next to it, okay? They tend to go hand in hand. Posterior tib's good. Takes you to deltoid, takes you to spring ligament, all right? So that's your medial ankle, and then your tibial nerve back here for those who do nerve work. If we follow that, let me drop my depth a little bit. You can start to see it divide into two parts right about here. There's one, two, probably medial and lateral branches right there. And again, everybody has a little bit of variable anatomy. And then the flexor hallucis longus. Can you wiggle your great toe, Lori? Yeah, let me see. I can do it for you. It's the red nail polish. That's what's doing it. So that's her FHL right there. Okay? And you can look at that in long axis. Remember, I mentioned I sometimes prefer to visualize it in the posterior ankle, but there's her posterior ankle recess, and then the FHL in long axis right here. There it is right there. And she's got a little tiny osteophyte back there. You can see that in the posterior ankle recess. Okay? Does that make sense? Good? All right, so we did anterior, medial. Let's do lateral. This is where, okay, so she's got some pathology lateral. So we're going to go to her left foot first. So, yeah, let's do this one. You got it. Wow, see, we practiced this. See, it's good that we did. All right, bring this closer to me. So now we're going to look at the fibular or perineal. I'm going to have nightmares tonight thinking of Jeff Cherkowski. I'm watching what I'm saying. You too, yeah, like it's, I hear you, Dave. Same thing. All right, so we're going to look at the perineal tendons or fibular tendons. So what we're seeing here is the peroneus brevis and the peroneus longus. Let me raise my depth up a little bit. Raise my focal zone. And this is what I was talking with Lori yesterday. She actually has, unfortunately, a split of her peroneus brevis. As I go down with this, let me put some more gel in here. It was this ankle, right, Lori? Was it this one? So, yeah, right? You can see that her longus invaginates and splits her brevis apart. Let me increase gain here. Yeah, go ahead and then roll your ankle a little bit. Yeah, right there. You can see her longus kind of splits her brevis in two. This is one part of the brevis, that's the other part of the brevis. So I'm going to cover this. This is from what's called intrasheath instability, where the two tendons kind of snap upon each other. Her retinaculum is intact, but you can see how much this is invading into her peroneus brevis. So this is the longus insinuating itself into the brevis over time, and she's developing a near full thickness split tear right through that, okay? If you're looking down, while I'm here, here's her calcaneofibular ligament right here, this linear structure, and if she dorsiflexes her ankle, yep, yeah, you see how that kind of lifts it a little, becomes more tight. That's a good way to look for the integrity of the CFL ligament right, yeah, right there. That's her CFL ligament right there, and it sits underneath her fibular or peroneal tendon, so that will take you to that. Okay? And this is why I was saying troubleshooting, if I had to go long axis on this thing, you know, you go, wow, what's what? But I think the split brevis, part of it is right here. That's one part of it. And then her longus is the bigger part of it. So that's why I think she has a near complete tear, split tear of that thing. Okay. Any questions about peroneus brevis? I got to show you the ATFL, okay? So let's lay supine and foot flat. I'm going to do her left because her right, she does not have an ATFL on her right side. So I'm going to start with the anterior distal tib-fib ligament. So to the right is the fibula. Let me bring up her depth. Try to show you this. Right here. So you see these fibers up there? That's her distal anterior inferior tib-fib ligament, an important structure to look at to maintain the integrity of your mortise. And then if I go distally, I'm going to stay on her fibula, I see the tibia drop away, and then I'm going to rotate the probe and point down towards her great toe. And there's a ligamentous structure. That's her ATFL. And, oh, come on. That's these little tiny perforating vessels that I'd sometimes look at. And if I see these drop down in here, I'm sometimes suspicious that that ligament tore. So that's a good picture. And again, there's a little bit of joint fluid that she has that you can use as an injection. So that's an ATFL. And people can stress test it if you want to. You want to do a little ankle draw, you can do that. Okay? Any questions about that? Good? All right, we have 2 minutes. Let me finish with the bottom of the foot. So if you want to lay prone. Oh, wait, there's gel down here. Hold on. I don't want you to lay in it. Okay, got it. Okay, let me get rid of this. All right, so let's turn our attention to her Achilles. Okay, let's see. Let's just go back with this one. So let's start with a. I got it. All right. All right, so if we go a little bit of plantar flexion, right, that gets rid of some anisotropy. Let's actually, you can relax, Laura. I'm going to go up to that calf real quick and just show you that anatomy that I was talking about. So medial is to the right, lateral is to the left, okay? And then in between, you can actually see the aponeurosis right here. So medial gastroc, lateral gastroc, soleus. And then if I go on the medial gastroc, this is where people tear. I'm going to go to long axis. And if you look right down here, this oftentimes will unzip like a zipper. It just peels apart. You'll sometimes see hematoma formation. Sarah, have you seen many of these? Yeah. Am I on with this? Is that about right, what you're seeing? Yeah. So it's pretty painful for people. They're quite disabled. The biggest concern is that they think they ruptured their Achilles, but then they get the good news. And if I'm correct, I think this may be a little plantaris right here, but we'll come back to that. Yeah. So as we follow that aponeurosis distally, again, I got about 2 minutes here. Here's where I was talking about. If you notice, see how that Achilles rotates? I just find that so cool. Look at it rotating. And it inserts in short axis onto the Achilles right there. I'm sorry, onto her calcaneus right there, I misspoke. And then I'm going to switch to long axis on the Achilles. And now this is where I want to do a little plantar flexion to get rid of that anisotropy. And here's that little small comma-shaped Phrygian helmet, retrocalcaneal bursa right there. That's about as much fluid as you want to see in there with Kager's fat pad here, okay? And you might get confused, but this is the flexor hallucis, this longest muscle. When I first started this, I called this the soleus. Her soleus is actually up here, the FHL. So wiggle your big toe again, Lori? Yeah, that's her FHL right there. And that's why I was saying sometimes I'll scan the FHL in the posterior ankle. Go ahead and wiggle your great, yeah. So that's her FHL again, the posterior ankle recess. So, all right, Achilles, and then sural nerve to make Jeff happy. I think, I'm probably not there, it's probably right. So you find the saphenous, and then that little honeycomb looking structure is her sural nerve right there. And then finally, let's go to plantar fascia. All right, so look at the difference, right? And then look at that. Okay, so not that I'm adept at changing the frequency on this machine. Res? Yeah, let's go here, pen. Let's see. There we go. Okay, good. Got it. All right, and then, so that is her plantar fascia. Here's calcaneal tubercle. And then you see these linear fibers coming off of it. Should be about 4 millimeters, which she may have a small little enthesophyte here. But that's a long axis view of the plantar fascia. And then we're going to rotate in short axis. And you can make it out right here. Oops, sorry, right here actually. And then as I push with my finger, you can see the fat going over top of it if you're planning some type of needling procedure, PRP or whatever, just to delineate what's fascia versus what. And you can follow that out distally if you need to. All right, and then finally getting down to the metatarsal phalangeal joint. So here's her FHL with the intermetatarsal ligament. Okay. So here's her two sesamoids, medial sesamoid, lateral sesamoid, intermetatarsal ligament. And then if I rotate the probe 90 degrees, yeah, and then go distally, you should see a ligament right there. That's the sesamoid phalangeal ligament. So this is what people get in turf toe. This is where they'll rupture, right in that area. Okay, and then finally Morton's neuroma. You get between the heads. Typically third and fourth is most common. So if we're between those two areas, and then we tend to squeeze and just look for a hypoechoic, oftentimes hypoechoic mass. The Morton's neuroma is between the third and fourth most typically is where we see. So we don't see any mass-like structure coming out in between. But again, in the right clinical scenario of paresthesias, burning pain in the toes, this is where we want to look, all right? All right, any questions? I'm a little bit over on time. Good? Try to cram it all in there.